Okay, so welcome back everyone to the third session of the day. This is going to be focusing on aspects of living with an inherited cardiac condition. I'm Steve Page, I'm a cardiologist in Leeds. Lynne Millar, my co-chair, is the senior registrar at Bart's Heart Centre and is the AICC trainee representative. So we've got 3 talks in this session covering some really important clinical aspects for patients: exercise and sports participation, family planning, and managing pregnancy in inherited cardiac conditions. And I think that this is such an important session because it really focuses on what really matters to patients. Now we've got a very generous 30 minutes at the end of the session for questions. So I think we'll have the 3 talks and then we'll pick up the questions at the end and hopefully have a really good discussion. So we're going to introduce the first speaker, which is Mike Papadakis from St George's Hospital in London. Be very familiar to many of you as a consultant cardiologist with an interest in inherited cardiac conditions, and is a particular expert in sports cardiology. Thank you, Mike.
Thank you very much for the kind introduction and for the invitation to speak today amongst such eminent speakers. My only conflict of interest relates my close association with cardiac risk in the young, which is a charity that tries to prevent sudden cardiac death in young individuals. So over the next 15 minutes or so, I will start by outlining some basic principles of exercise prescription, which are often ignored, particularly in the context of inherited cardiac conditions. And then I will focus on exercise prescription based on the recent 2020 ESC guidelines with a focus on hypertrophic cardiomyopathy. Given the time restriction, I will just briefly offer an overview for the rest of the cardiomyopathies and a single slide on the ion channelopathies. So let's start with the basics. It's important to establish that exercise is beneficial, and it's beneficial for healthy individuals, and it's also very beneficial for individuals who have established cardiovascular disease. And there is also a dose-response relationship, which is evident in this graph here, where what I've done is I've presented to you, instead of the reduction in mortality, I've presented the life years gained from exercise to give the positive message. And I would like to reiterate 3 things. The first thing is that for people who fulfill the minimum criteria, those 150 minutes of regular exercise per week, they may gain up to 3.4 years of life compared to sedentary individuals. But it's important to note the steep aspect of the curve at the very beginning, and individuals who do only a third of the recommendations can also gain up to close to 2 years of life compared to sedentary individuals. And the more you exercise, the more you gain, with individuals who do 3 times the recommended amount, gaining up to 4.3 years. So, I know that regarding inherited cardiac conditions, there are concerns regarding exercise, and those concerns stem particularly from high intensity and competitive sport. So the concern has always been that if you've got an unstable electrophysiological substrate, and here is an example of hypertrophic cardiomyopathy, and you add the adrenergic surges of exercise, then you may cause ventricular tachycardia, ventricular fibrillation, and sudden cardiac arrest. However, the reality is that most individuals with inherited cardiac conditions will greatly benefit from physical activity and moderate levels of exertion. So the way I want to present it to you is, don't ask yourself whether they should participate in physical activity of exercise, but you need to have a really good reason in order to take them away from those minimal recommendations to less levels of physical activity and exercise. And here you see the 150 minutes of moderate exercise or 75 of vigorous exercise, combined very importantly with some strength training as well as exercise to improve balance, particularly in older ages. Now, how should we do assessment of individuals for exercise prescription in individuals with inherited cardiac conditions? Well, some basic principles. We need to take a good history and know the condition that we're looking at. Then we need to establish what are the current levels of exercise, and then what do they want to do. As you realize, the scenario of someone who exercises on a regular basis and wants to continue with the same amount of exercise compared to someone who has not exercised before, has hypertrophic cardiomyopathy and now wants to run the London Marathon is a completely different perspective. Then you will do your assessment, and then ideally you'll end up with an individualized exercise prescription for that particular patient. Now, it's a very important message that that exercise prescription needs to be very specific. Saying to someone that they should do moderate or low intensity exercise doesn't mean anything unless you quantify it. This is the basic FIT principle that we use for exercise prescription. So you should tell them how often, at what intensity, for how long, and what type of sport would you recommend. And ideally, you will end up with this sort of figure that has the aerobic as well as the strength training, and provide them with some numbers that fulfill the frequency, intensity, and duration of exercise that we quoted. In terms of intensity, just because it's often asked, this is the EAPC, the European Association of Preventive Cardiology classification of the intensity, separated to low, moderate, high, and very high. There are a number of ways that we can do that. We often use exercise testing and cardiopulmonary exercise testing in our ICC patients. A lot of you will be more familiar with the maximum heart rate. The heart rate reserve takes into account the resting heart rate of the individual, and don't forget the relative perceived exertion, the board scale, which correlates very well with intensity of exercise, and it can be extremely useful, particularly for patients who can, for example, wear a heart rate monitor, either because they've got an arrhythmia or because they're on different medical treatments. And coming to the 2020 ESC guidelines, this is an extremely useful document, and I would highly recommend that you read it and try and use it in your clinical practice. It provides a very structured approach to exercise prescription. It addresses exercise across all different levels, not just competitive athletes. It takes into consideration the athlete's wishes, and it definitely takes a more liberal approach compared to previous recommendations. So the 5 basic messages are: get the diagnosis right, and that can be challenging, particularly in elite athletic individuals who may exhibit adaptations that overlap with inherited cardiac conditions. Do your risk stratification, then discuss your findings with your patient and involve him in the decision. Give them the right treatment and help them to participate in exercise in a safe way and achieve their goals. Let's go to our clinical case scenario. So we've got a 25-year-old footballer. He is completely asymptomatic with no significant family history, and he goes to a screening. You can see from his 12-lead ECG that he's got voltage criteria for left ventricular hypertrophy with widespread repolarization anomalies, fairly typical of an apical form of hypertrophic cardiomyopathy, which is confirmed on your echocardiographic and cardiac MRI imaging. So what do the guidelines say? First of all, they ask the question, is exercise as deleterious as previously thought in hypertrophic cardiomyopathy? And they rightly ask that question because the evidence suggests that in more contemporary registries of sudden cardiac death, even in competitive athletes, hypertrophic cardiomyopathy possibly plays a lesser role than previously thought. There is some initial data in small cohorts, admittedly, of amateur athletes that those who discontinue exercise do not fare better compared to those who continue exercise. There are a couple of cardiac rehabilitation and exercise programs that demonstrate that up to high intensity exercise can be safe and give the relative benefits to hypertrophic cardiomyopathy patients in terms of cardiovascular risk factors such as hypertension and hyperlipidemia, which seem to play an important role, particularly after the talk that you had earlier from Professor Hugh Watkins. And also there are even some animal models that suggest that exercise, particularly if it starts quite early, can be beneficial in preventing the development of myocardial disarray and even fibrosis and hypertrophic cardiomyopathy. So what the recommendation says, do a comprehensive evaluation, and here I've outlined for you the evaluation that you will probably do in your regular practice, looking for all these risk factors that will allow you to assess the risk of a regular patient. For exercise test and ECG monitoring, arrhythmias play a very important role, and also exercise testing will allow you to look at the hemodynamic response to exercise, but also assess the fitness, the exercise capacity of your patient. I've put cardiac MRI here as it may play a role. This is a bit more controversial, but it can be useful particularly for patients who have extensive myocardial fibrosis. So then, what the guidelines say, use the established risk stratification that the European Society of Cardiology has produced. And I know that this has not been validated in athletic individuals, but I think it's one of the best things we've got in terms of risk stratification in individuals. And what they say is that you can classify them, extrapolate and classify them as possibly low, moderate, or high risk individuals. And then discuss with your patient the results of your evaluation and try to take a more holistic approach in terms of the safety of exercise and the right level of exercise in this particular individual compared to the individual wishes and personal choice. And what the recommendations advocate, which is a major change compared to previous recommendations, is that actually individuals that are considered to be at low risk of events, so they don't exhibit any significant risk markers, may be able to participate in high intensity and competitive sport. For the rest, they recommend low to moderate intensity recreational exercise. And the markers they look at are symptoms, the ESC risk score, whether there is an inducible LVOT gradient, the blood pressure response to exercise, and the presence of significant arrhythmias at rest or during exercise. Very important to remember that once you're done with your exercise prescription, you need to keep monitoring your patient. Depending on the level of exercise, you may require more frequent monitoring than once a year, particularly looking for the arrhythmias. And the other things not to forget is educate them about symptoms, when do they need to come back to you, and about looking after themselves in terms of hydration, the electrolyte and other supplements they may take, and don't forget performance-enhancing substances. And especially for competitive sports, there should be an emergency response plan in the case of arrhythmia and cardiac arrest. A word of caution, remember that these guidelines are consensus-based guidelines and level of evidence C. So be aware of the increased risk in younger individuals. Be aware of the increased risk of high-intensity interval training, like start-stop sports like football and basketball. And at the end of the day, you need to ask the question, what are you trying to achieve here? Is this an elite professional football player whose career and life depends on it? Or is it an amateur exerciser who can swap from football to regular running? Very briefly before I finish, regarding exercise recommendation in DCM and non-compaction, they follow the HCM paradigm. So people with low risk, mild disease, can potentially participate in high-intensity sport. Unfortunately, the story is quite different for arrhythmogenic cardiomyopathy, where we've got increasing evidence that high-intensity exercise can bring forward the natural history of the condition and increase the risk of sudden cardiac death, and therefore the recommendations are very conservative, even for genotype positive, phenotype negative individuals. But still, they should be able to participate in low and potentially moderate intensity recreational sport. Regarding the ion channelopathies, just a slide on that. I've done a traffic light system for you because we don't have the time. But for Brugada syndrome, a fairly liberal approach to exercise. For long QT, a fairly liberal approach on optimal medical therapy with a bit of divide between Europe and US regarding individuals who have a fairly prolonged QT interval. And for CPVT, due to the nature of the condition, a very conservative approach, which may be reviewed in genotype positive, phenotype negative individuals on optimal medical therapy. So in conclusion, exercise prescription should be done in a very systematic and structured approach in both assessment and the actual prescription. And remember the FIT principle, taking into account the patient's views. Recommendations are gradually becoming more liberal for a number of the inherited cardiac conditions, with notable exceptions, the arrhythmogenic cardiomyopathy and CPVT. And as the figure says here, exercise should definitely go on for most individuals, whether they go to high intensity or competitive sport. That will depend on individual circumstances. And there is no doubt that we do need more data in order to be able to support the recommendations that we make to our patients. Thank you very much for your attention. And if you're interested in sports cardiology and inherited cardiac conditions, have a look at the St. George's University website for our MSc. Thank you.
Thanks, Michael, for an excellent talk. I'm sure there'll be lots of questions in the panel discussion a little bit later. In the interest of time, we're going to move on to Ellie Quinn,